Welcome everyone. Welcome to Provincial Grand Rounds. We have a special speaker today and a special presentation that you can see up on your screen. Pay attention as well to the chat box as we move forward and have a look at the instructions regarding your name and so we can keep attendance, etc. And before we start, I'll do a land acknowledgement based on geographically where I am, and you can certainly echo that yourselves wherever you are. We respectfully acknowledge that we are here today as uninvited guests on the unceded territory, traditional territory, of the Coast Salish peoples, including the territories of the Musqueam, Squamish, nations. So welcome. And without further ado, we've got Dr. Alec Ritchie today, who assures me that he completed medical school at the University of British Columbia many, many years ago. He wouldn't give me the date. He did an internship at the Royal Columbian Hospital and his emergency medicine residency at the University of Western Ontario. He's an emergency physician, clinician extraordinaire at Lionsgate Hospital in North Vancouver. Many of you know him. He's also an EPOS, or emergency EMS physician on call, physician for BCEHS, and is a medical consultant for BCEHS as well, and has done that for many years. He's a clinical associate professor in the Department of Emergency Medicine at UBC. He enjoys mountainous activity, as you'll see, and his favorite form of exercise is going uphill on boots, crampons, skis, or bicycle, and I think we'll see as well. Combining his interest in emergency medicine and his love of the mountains, he became a member of the North Shore Rescue, a volunteer ski patroller for Whistler Mountain, and a staff physician at Mike Wiegele's helicopter skiing in Blue River. Alec, take it away, but before you do, reminder to everyone, press your mute buttons, use the chat box, and I'll adjudicate questions about halfway through. Dr. Ritchie.
Thanks very much, John, and here we go. So we usually begin with a disclosure. I'm a member of North Shore Rescue. I don't get any money from them for doing this. And in fact, it costs me money, but I really love the experience and I'm hoping to share some of that with you. Here's what I hope to talk about today. I'll start with some facts and stats and hopefully not bore you, but tell you a bit about search and rescue and specifically about North Shore Rescue. After that, I wanted, the meat of the matter is in yellow there. So for myself, I've developed three paradigms that I personally try to consider for each and every SAR medical call because they help me organize my thoughts. And I thought you might find them interesting too. And my hope is that we'll apply these three paradigms to some actual medical cases that we've done. There are 5 of them, and hopefully we get through them all. And I'll end with a bit of a review and epilogue after that. So how did I get involved in search and rescue? Well, close to a decade ago, I sort of had this midlife crisis, and I decided I wanted to spend more time in the mountains and less time in the emergency department. So much to the chagrin of my wife and my accountant, I cut back a lot in work and started just wandering in the mountains a bit more, having a bit more fun. And that within a short while led me to join Whistler as a volunteer dock patroller and join North Shore Rescue. And I landed a sweet gig up at Mike Wiegel's being a heli ski dock. And I quite liked that stuff, so I continued it. And I worked a little bit less, as my wife would say, for money, and spent a lot more time doing stuff in the mountains for no money. I didn't necessarily follow the path that you should if you're interested in this sort of stuff. I kind of went to the school of hard knocks, and I'll share that with you unabashedly. But if you are going to do this, if you're thinking you want to do it, you want to pay attention to some of those references I've got up there. The International Commission on Alpine Rescue, or ICAR, based out of Europe, and specifically they've got a medical committee. That's where you want to start learning your good medical stuff from. And they offer a course called the Diploma in Mountain Medicine, or DIM. You get to put D-I-M-M after your name, which is kind of nice, DIM. That's internationally recognized worldwide as one of the best ways to educate yourself on mountain medicine. You'll see down there the Canadian Society of Mountain Medicine. They offer DIM courses here in Canada, and those courses actually are offered around the world too. The Wilderness Medical Society has been in place for a long time in the United States. So you've got a European component, an American component, a Canadian component, and fairly new on the scene is the Canadian Association of Wilderness Medicine. So if you want good knowledge about that, turn off this talk now and go to those websites. Well, no, stick around for a while. Search and rescue in British Columbia, well, like everywhere in Canada, it's a volunteer way of doing things. There are 84 volunteer search and rescue teams in British Columbia, and they're all under sort of the umbrella of EMBC. How do you become a team member? Well, you got to do a course, GSAR, or Ground Search and Rescue, a formal course via the Justice Institute. And certainly for North Shore Rescue, you're a member in training for 2 years before if you pass your written and practical exams and you graduate to a full member. How does search and rescue teams get access? Well, we don't just sit around on a Saturday night and say, hey, let's go in the mountains, let's go on a call. We have to be tasked by a government agency like police or fire or ambulance or the coroner for search and rescue missions. They contact our search manager contacts us, and a call is initiated. Specifically for North Shore Rescue, we are one of the 84 volunteer search and rescue teams in BC, but we are the busiest and we are the largest. We have about 40 active members and we have about 30 resource members. The active members actually go in the field and do search and rescue work. The resource members are also very important, however, and while they don't go in the field, they help us out a lot with maybe some of the behind-the-scenes stuff. For example, we've got mechanics that take care of our vehicles. We've got snowmobile operators that tow us in. We've got some swift water, whitewater people that don't come out except for when there's whitewater rescues going on. So the resource members, we've got an IT person who takes care of all our technology. So they're very important as well. Some stats, we're getting very busy. You'll see the bar in 2020 is smaller. No, that's only because we have incomplete data for 2020. So the exponential rise is continuing. Last year was a record year with 146 call-outs. And every year in the last 5 years, or at least the average in the last 5 years, has been over 130 calls per year. Now, we don't send out a huge number of members on every single one of those calls. Some of them can be managed over the phone or with a small number of members going into the field. But still, things are getting very, very busy. You'll see that we're busy every month of the year. Of course, July and August are the busiest, but it's not by a lot. Every day of the week, Saturday, Sunday busiest, but we go out 24/7, 365. Cypress, Grouse, and Seymour, the 3 mountains we serve, are our busiest places to go, but we also do mutual aid, which means other SAR teams in the province can call and we go help them, and sometimes we call them and they come help us too. We'll go out on urban calls, for example, a demented walkaway. We'll often check the parks and the trails and stuff like that, and other. Usually we go for hikers, but you know, it's people on snow, bike. I mentioned urban and other. We go out for all different types of activities. And again, 2020 looks shorter, but that's incomplete data for 2020. The number of subjects going up. The injuries are kind of up and down, but staying about stable. And sadly, there's not a year that goes by when we don't take dead people out of the mountains. And if you've been following the news this year already, we've had a tragic case of a 21-year-old female dying on the nearest St. Mark's summit. About a third of our calls are medical, with about a third of those being CTAS 1, 2, or 3 types. Now, some people watching might not know what CTAS is. CTAS is the Canadian Triage and Acuity Score, and it's from 1 to 5, with 4 and 5 being minor things. So a CTAS 1 would be a person actively seizing or in cardiac arrest. CTAS 2 would be someone severely short of breath or severe, anginal chest pain, and a CTAS 3 would maybe be abdominal pain or pelvic pain. So CTAS 1, 2, or 3 are more significant medical problems, not just your twisted ankle. So if a third of North Shore Rescue calls are medical, and if a third of those are CTAS 1, 2, or 3, you can see that we've got a not insignificant number of serious medical calls. So in 2018, we developed an AMP program, or Advanced Medical Provider, and we brought them on as resource members. So they all needed to have prior a knowledge and skill in the backcountry, but we gave them some basic ground search and rescue knowledge and skills as well. And they're now resource members of the team. And there's 10 names on the left there. You'll recognize a lot of them. Myself and Kayla Brawley. Kayla is an emergency nurse and a great NSR teammate. She was a ski patroller and a RAP attack forest firefighter before that. Kayla and I are full members, and the rest are resource members. 2 of them were actually past full members. Almost all of them emerged docs at Lionsgate, a couple representing Royal Columbia, and Carolyn Kelly Smith, an emerged doc there, and Brady Warnick, an anesthesiologist there. I use some of those names because they'll be coming up later. You'll see. Anyway, we've got lots of medical equipment, lots of meds, and basically we can provide advanced medical care in the mountains. In 2018, we broke down what we were actually going in for. There were 45 medical calls that year, and again, a third of them, 15 were what we thought were AMT calls, a couple fractured femurs, penetrating abdominal trauma, shoulder dislocation, chest trauma, multiple trauma, multiple trauma in a pregnant patient, scalp laceration, rule out traumatic brain injury, ill diabetic, drug abuse, multiple trauma, suicidal, alcohol intoxicated. Sounds like your average emerge stuff. Spinal cord injury with paraplegia, thoracic brain injury, seizing, compound tib fib, and heat illness resulting in confused, so a good brain hit on that. And then the non-AMT calls, like 17 MSK leg injuries, and the rest you'll see there. Those are the sort of calls that we're going for. You people are the first outside of the Medical Advisory Committee of North Shore Rescue to hear about this research paper and these stats. We are currently doing a research paper looking at 25 years of North Shore medical calls. And I can give you our preliminary results up to 2015. 41% of our calls were medical. And I was a bit surprised at the breakdown. 58% were for trauma. I thought it would be higher, and 42% were non-traumatic. Top 3 trauma things, MSK, which we knew, blunt force trauma, abrasion, contusion, so pretty much expected. I was a bit surprised, top 3 non-trauma calls, hypothermia, psychiatric being number 2, and just exhaustion or weakness, which remember is an ICD-9 code, or ICD-10, was the third most common non-traumatic call. All right, I want to switch gears here and discuss 3 paradigms that I personally use, sort of invented in my own mind, to help me personally through each medical call. I'll comment on some of the photos. Every photo, unless I say, is an actual photo of an actual call in the North Shore here with the NSR. This was a boring call, so I'm not going to go into deep detail. This is just a 25-ish-year-old male with his first ever tonic-clonic seizure on the top of Coliseum. But hey, you got North Shore Mountains, you got a helicopter, you got bright colored clothing, you got people in helmets. It's a good photo. Paradigm number 1, situational awareness. Anybody that spends a lot of time in the mountains knows about this, but maybe emerge docs that do all their medicine in the emerge don't think about such things. Things like the scene and your personal safety. I've got STS there because that's what you always remember. It's even on your GSAR exam. If you can save 1 life, save yourself. If you can save 2 lives, save yourself and your teammate. If you can save 3 lives, self, teammate, and then and only then, subject. So you want to make sure that you're safe first. That's the number 1 priority. Then you think about things like, what time of the day is it? What time does sunset tonight? How much daylight do I have left? What's the weather? What's the cloud cover look like? What's the temperature now? What's it going to be in an hour or 2 from now? What am I standing on? Is it dirt? Is it snow? Is it ice? Is it flat? Is it 30 degrees? Is it 55 degrees? What's my access and what's my egress? Is it going to be easy to walk out of here? Do I need ropes to pull somebody out of here? And finally, how am I traveling? Am I on foot? And if so, am I on skis or crampons or boots? Am I traveling by a motor vehicle or am I flying in? So these non-medical logistics are very, very important, and they're sort of the first thing that you start thinking about. Secondly is ICS, Incident Command System, and probably everybody's heard of that. But as emerge docs, I think we're used to maybe being the one calling the shots, or at least being an important team member, and we hear our voice a lot in the resuscitation room. Well, in these calls, there is someone in charge, and you are not that person. And it took me a while to figure that out. Even in the sick patients, you're not in charge of the whole situation. Okay, so all big and good teams like military, police, fire, ambulance, they use ICS, and it's a good way to be effective in these sort of situations. The teamwork is very, very important. And there's a commander that's not in the field, and they're on the radio, and they're looking at the logistics from the 30,000-foot viewpoint. When you go in as a team, there'll be a team leader, but usually you're not the team leader. And as a SAR medic, frankly, you don't want to be the team leader, because if you can task everybody with one important thing, you can avoid the cognitive overload. As team leader, you're worried about the logistics and access egress and the safety of the entire team. I'd rather just go in as the doc and have to worry about the medical issues with the patient or subject, and leave other logistics to the team leader. So again, if you task everybody with something that they can do and they can understand, it avoids this cognitive overload, and it's a good way to approach this. Communications are important and are often done via radio. You got to remember that as a good SAR team member, if you're not the team leader, you don't even communicate with command. You communicate usually just by voice with your team leader. The team leader communicates with command. If you want to speak to another team, usually you do it via command, or you ask command permission. Can I speak directly to team 7-7? So comms, communications are important, and they take a bit of learning.
By one family inquiry.
Let's get everybody to mute their mics, please. The concept of subject.
Can this guy go and come back?
Somebody's in an emergency department.
Can you leave one on the board for me?
I will 100%.
Yeah.
Graham Gallons, mute your mic, please. The concept of subject versus patient is a really important one. It took a while to figure that out. So for most people in search and rescue, they go searching for a subject, and that subject might be injured, and the subject is what they're thinking about and working towards. We tend to think of patients, and when subject becomes patient is a very interesting point, and that's where I spend a lot of my time and my thoughts. Initially you're going in towards the subject, but again, if they're injured or sick, they're also a patient. So I encourage you to think of them as both. Finally, and in small font, is the term leadership. And it is the final one, and it is in small font for a reason. And I think I'll leave that for now because it'll come up in one of the cases later. We'll talk about leadership. So that's the second paradigm that I think is very important. The third paradigm are the medical and clinical details of the call. And I can hear a collective sigh of relief where all the emergency physicians or nurses in the crowd. Oh, good. At least we know this part. Well, I would say, do you? The medical and clinical details, for me anyway, are different in the mountains or the backcountry. You have to think about things differently. So you may have what your diagnosis is and what you think the acuity is, but are things urgent or emergent? Do I have to deal with this right now, or is recognition of it and dealing with it at some point in the future, is that adequate? Something as simple as vital signs and monitoring. Yes, I want full vital signs and a blood glucose, please. Well, when was the last time that you personally took a blood glucose off a patient? Do you know how to work the machine? Okay. Do you know how to put the monitoring leads on? Where does the red lead go again? Is that right shoulder or left shoulder or the hip? So you have to do all these things yourself. I want the patient to have an IV. Okay, you put the IV in. And if you want a line, then you prime the line and spike the bag and all that other order. Spike the bag and prime the line, all that sort of thing. So, you want them to have oxygen. Can you manage the tank and the regulator and the tubing? So these are things that maybe you don't think about right off the bat. Medications. Yes, I want to give meds. Well, how do you want to give it? Well, chances are it's not going to be PO. Are you going to put the IV in? Do you want to give it IM? Luckily, intranasal works really well for certain meds, and we can always do IO if you've got the right toys to play with in the mountains, intraosseous. Splinting and packaging, all eyes will be on you, although I can tell you a lot of my teammates do a better job of the splinting and packaging than I do, but I'm learning. By the way, ARP stands for Aerial Rescue Platform, the flying stretcher on the end of the long line. You'll see that later. I have to manage the airway. Really? You're going to put a tube in this guy now? He needs a chest tube. Really? Right now on the side of the mountain? So you have to think about these things, and basically at the end of the day, is it stay and play, or is it load and go? Or is it some small combination of the two? These are really important things to think of when it comes to each medical encounter. So my plan now is to discuss some cases, and hopefully we have time to do 5 of them. And I want to apply those 3 paradigms to each case. And basically, I'm going to put you in each case, and I'm going to say, you do this, you now do that, what are your thoughts? Because I want to get you guys thinking. If this was in person, in the times of non-COVID, it'd be much more interesting because we would do them in an interactive way. I don't know why that came up. By the way, the photos I said are real. That's Kayla Brawley, emerge nurse at Lionsgate Hospital. On the back, I think in something called Tony Baker Gully off the back of Hollyburn near Cyprus, with a 60-ish-year-old man who had been in an avalanche. His companion dug him out. I believe this guy has some broken ribs, a fractured pelvis, and a fractured leg. And Kayla's taking expert care of her. I'm not going to discuss this case because I was working the emerge that day. It's Kayla's case behind. But these are the type of things we're looking at. John, I said I'd stop about halfway through. I'm going to go into some cases now, so maybe I'll take a question or 2 before I jump into the cases, if there are any.
There's nothing on the chat line now except frank adoration of you. So you can actually...
Good. Moving ahead quickly then.
There's about 116, 115 people as well, so it's a bit tricky to take questions from the actual platform itself. So people choose the
reason
chat.
there's so many people is that the weather's not very nice today. They've got nothing better to do. So here we go. Moving ahead, let's discuss some cases. So case number 1, that's a Google Earth shot with a pin drop at some coordinates. And for those of you that know the area, I'm sure tons of you like me know that that's the gully between 2nd and 3rd peak. And you know there's that off-angle steep bit in there that you never want to fall when you cross. And this 60-year-old man decided to fall exactly there. So again, you are going to be thrust into this. What do you think? What are you going to do? So it's late November, it's 3 in the afternoon. Now you're new to this SAR team. You've been a member for maybe a year or so. This is the first big call you're going on. And this 60-year-old man was hiking solo on Seymour, and he was wearing snowshoes in mixed conditions. You never wear snowshoes in mixed conditions. You basically got a toboggan on each foot. And he's traveling between 2nd and 3rd peak. 2nd peak is now formally called Tim Jones Peak. You may know that. You may know that Tim Jones was an advanced care life support paramedic for BCEHS who died actually on Seymour, hiking back from the North Shore Rescue cabin. He was a long-time team leader for North Shore Rescue, and his death was one of the reasons I thought maybe I'd like to join North Shore Rescue, because we lost a lot of great medical care when Tim died, and some of us are hoping to replace some of that. Anyway, back to our 60-year-old man. He falls down that steep slope. He falls 15 or 20 meters down about a 45 or 50 degree incline. His fall and his injuries, his multiple injuries, are significant. Luckily, 3 young people who had been hiking back from 3rd Peak saw him. They call 911, and 911 gets a hold of NSR, and we go for a rescue. So those are actual weather stats from that day. Much like right now, a polar vortex was in, and there were very cold temperatures. Those are the temperatures at YVR, so they were much colder on Seymour that day, and that night they'd be extremely cold. Sunset's going to be at 18 minutes after 4 in the afternoon, and that's important because our helicopters back then don't fly at night. Although if you've been watching the news, NSR now does have night vision goggles, but back then we could not fly at night. Luckily, it's a clear day. So you arrive at the search and rescue station, the Heli landing zone. That's a file photo of our fearless leader, Mike Danks. Mike's a firefighter, rescuer extraordinaire, and a calm, clear thinker and a great leader. Mike tells you that you've got a 60-year-old man. He had a big fall. We know he has an arm injury. We know he's bleeding from his head, but he's conscious. He was initially standing up and seemed to be walking. So look, here's the plan. We have a time-compressed call. It's getting dark. We don't have a lot of time. Let's heli in. Let's do a hover exit, which I'll explain. Then the machine's going to take off and land as close as they can, but they can't land at the site the patient's at. You get to the patient, you walk them up to the machine, and you get out of Dodge before it gets dark. That's the plan. So you and a teammate fly into the site. Now, a hover exit is getting out of the helicopter when it does not have its skids fully on the ground. And it's commonly done, and there's somebody getting ready to execute a hover exit. It's not jumping out of a helicopter. It requires a bit more skill than that, but it's not that big a deal. So anyway, we hover exit, we hike over to the next gully, we get to the subject in the group. I went back to this site the next day because it was a nice day for hiking, and I knew it would be a good call, and I wanted to get some photos. So these are photos the next day. Where the patient fell from is circled in red on the left. That's water ice. Anybody that's in the mountains know that compacted snow becomes icy, but that's actual water ice. So it's water that's frozen as it's cascaded down those rocks. And the photo on the right is a person standing where the subject was laying. That's where he fell to. I didn't take it straight down because I didn't want to take the photo from the point the subject fell, because it was a point where you have a very little purchase, and I wanted to get across that slope very quickly myself. I was wearing crampons and using an ice axe. I was not wearing snowshoes when I did this. Anyway, you get to this patient, and he's lying in the snow, and his head's cocked in a weird position, and he won't look at you. So you stand there and go, "Hey man, how you doing? Look at me." He says, "I can't. It hurts when I move my neck." He's Glasgow 14, so he's a bit confused. His heart rate's 110 at the wrist. Fairly good volume there. 24 breaths a minute, 92% on ambient air oxygen saturation. Airway's okay, breathing's unlabored, and his thorax is stable, but he does have some left-sided chest tenderness. He's pale, he's shivering. The pulse volume at the wrist, as I said, was normal. He's alert, but slow to answer, maybe confused. His neck is tender, but he can move all four. And he's got some tenderness on his left shoulder. It is now 10 minutes after 4 in the afternoon. I should have paused and got you guys thinking, but we don't have a lot of time, and I can't interact with the audience anyway, so here were some of my thoughts on situational awareness. It's late in the day. We have a time-compressed call. It's very cold already and going to get even colder tonight. We are in technical winter terrain. Remember, your commander said, "Get in there, quick snatch and grab." And it takes a long time to configure the helicopter for HEC. And by the way, HEC is human external cargo. That's the proper term for the other term, the colloquial term, long line. But if we're going to long line this guy, it's going to take a while to reconfigure the machine. Now you're new to the team. And this is where leadership comes in, I think. This is the one time where you have to be a leader, you have to be an advocate for your patient and do the right thing and say to command, "No, this guy can't walk. No, we're not going to drag this guy out on the toboggan. This guy needs to get out now. He's multiply injured, and I think he's got a broken neck." So command trusts you, which is good. Thousands wouldn't, but the commander does trust you. And they go, "Okay, fine, it's going to be a real rush, but we'll rig for HEC." While they do that, you turn to the medical details. This guy's really cold. You better try to warm him up. He's a geriatric multiple trauma that's going to be hypothermic. This does not bode well. What are you going to do? Well, let's get a C collar on him, although we don't use cervical collars a lot for good reason in the backcountry. This guy, I figure, does deserve one. Let's get a heat vest on him and a sleeping bag and wrap him in a tarp over that in what's called a hypothermia burrito. I personally, I didn't do a lot of other medical care. I'm a bad doctor. I didn't even splint or sling his arm because I wanted to have this guy ready when the ARP arrived. And these are actual photos of the HEC tech with the ARP of that patient. That's actually when he was landing at Mount Seymour. And in the picture in the bottom right, that's Carolyn Kelly Smith, who was also dispatched this call. But I got, I guess, quicker to the Heli LZ, so she drove up to Mount Seymour in case a ground team had to go in, and she helped receive the guy at Mount Seymour, put him in the ambulance, jumped in the ambulance with him, and then, got an IV in a bed and started giving analgesia and helping the paramedics take care of him en route to Lionsgate Hospital. So what's going on with this guy? Well, he was bleeding in his brain bilaterally. That's his comminuted T2 fracture. That's his large left pneumo. And remember I said his left shoulder was sore? Oh yeah, that doesn't look very good either. So he's got subdural hematoma, traumatic subarachnoid hemorrhage, hemorrhaging into both ventricles. That C2 fracture did go right into the transverse foramen, but luckily they did an angiogram. He had no vertebral artery injury. Large left pneumo with multiple rib fractures, and that left shoulder was a mess. He does well in hospital, however. He doesn't swell, no neurological problems but other than headache and vertigo. His C-spine was stable, his pneumo resolved, his shoulder was fixed. He was discharged home on post-injury day number 10, and 3 days after that went to ortho clinic.
Oh, my love, I just don't want you to work.
That was case number 1. Case number 2, again on Mount Seymour. We'll see that Seymour is a very evil place. This guy's on the way back one of the mountain bike trails called Cambodia. Some of you have probably ridden that, and it's sort of one of the more northernmost trails on Seymour, buried way back there, and it's noon in July, and this guy crashes coming off that rock, probably got some air. NSR was geared up that day because we're on medical standby for the Neenacker race, which is a race from Deep Cove, or pardon me, from Horseshoe Bay to Deep Cove, and a super long, ultra technical backcountry race. So we're always doing medical care for that. So we've got the whole team on standby. We've got a helicopter on standby. We've got HEC techs on standby. We're ready to go. And you're sitting with Mike Danks, again, North Shore Rescue Team leader, and he's a firefighter, so he's got his fire radio on as well. And you hear some chatter through his radio that, oh yeah, fire is going to some mountain bike place on Seymour for this mountain biker who's got a left chest injury. So Mike gets on the radio and very nicely says, hi guys, we're all geared up. Need any help? And they said, no, we got this. So there's a lot of radio chatter, and they get there, and the patient doesn't look well. And now he's having abdominal pain, and then later, now he's having left shoulder pain. So via the radio, you get Mike to ask the firefighters to examine this guy's left shoulder. Well, the guy's having shoulder pain, but there's nothing wrong with his shoulder. So basically, no mystery here. Over the radio, you can diagnose his ruptured spleen. So you and an NSR teammate who's a PCP paramedic, you drive to the closest road access, and you get to this patient with 20 minutes of really fast hiking. Now, you drove to a different access point than fire did because you had a bit maybe better knowledge. And fire actually, it probably took them at least 30 minutes to get to this guy. The terrain is rough and hilly as it is on the North Shore mountain bike trails. You get there and fire, Metro Vancouver, uniformed, and uniformed BCEHS paramedic are actually on scene. Why they hiked in so far, I don't know. Patient's lying supine in the stretcher, and he's already been packaged by fire, but the patient looks very, very unwell. You can see his vital signs there. His left chest wall's tender, but his belly's the worst, and he's got a rigid belly, he's got peritonism, and of course his left shoulder is more. So you have good weather, lots of daylight time, but you're deep, deep in the forest, you're long distance from any roads, and the terrain's not super easy. It's not exactly technical, but to get out of there as a stretcher, you might have to do a couple belay type things. Now luckily, NSR is geared up for the Neenacker race already. However, the patient belongs to fire and EHS. So you don't go in there guns a-blazing. You go in there maybe hat in hand and say, hey guys, great job. Thanks for packaging him. Thanks for giving the vital signs over the radio. Listen, this guy's pretty sick. I'm an emerge doc. Do you mind if I assume care of your patient? And of course they say yes. And then you say, look, this guy needs to get out of here really quick, and I'm worried about you carrying him over this bumpy terrain and how long that would take. I think flying out on the end of the long line would be a good idea. What do you think? And they say yes. And then you've assumed care of the medical care of the patient and assumed the logistics of the egress as well, of the evacuation. Now you turn over the logistics of the evac to your teammate, and your teammate works on getting a HEC site and is communicating with command while you're seeing to the patient. The medical details, well, an intravenous is a good idea. TXA would be an excellent idea. At that point in time, we did not carry TXA. We do now, and based on that case. It'd be good to maybe talk to the hospital, maybe some analgesia, maybe not. Because as you're waiting for HEC, this guy gets worse. By the way, you can delegate things to people that can do things as well or better than you, like get an IV. And this guy's getting worse. He's starting to get a bit sleepy. His blood pressure is dropping. His heart rate is rising. And he starts to vomit. And he's going to be lying flat on the aerial rescue platform. Now what? Well, I'm a believer in grab all for motion sickness and use it a fair amount in situations like this. And for what it's worth, gave the guy 250 mils of hypertonic saline. Hypertonic saline as a volume expander is pretty controversial, not a lot of good evidence, but hey, it's only 250 mils, which is a quarter of the weight and a quarter of the size of carrying a liter of saline. This guy caused a bit of a kerfuffle when he finally got to Lionsgate Hospital Emergency Department. That's an actual photo of the event. Emergency doctors, the trauma team leader, the surgeon, an anesthesiologist, nurses, laboratory technicians, RTs, paramedics were all in the room together. They intubated the patient pretty quick because he wasn't doing well. He kept vomiting and dropping his sats. Ultrasound showed a belly full of blood, as you can imagine. He got 2 bags of blood in the emerge right away and went straight to the OR without a CT scan first, which was the right thing to do, but in my world anyway, happens very rarely. So they go in there, he's indeed got a belly full of blood. They take out his ruptured spleen. They give him 3 more units of blood intraoperatively. The guy does well, home on post-op day 3, complete recovery. Isn't social media great? 49-year-old man hiking on Dog Mountain starts to get chest pain. So for those of you that know Dog Mountain hike, you can see on that little map to your right, those straight lines are the Seymour ski lifts. And the Dog Mountain Trail is the lower red trail that heads out to your left, that is to the west. It's Dog Mountain, which is a nice view of the city. It's a relatively flat hike. It's a 5-ish K. It's a nice little hike, and in the wintertime it's nice to do mostly on crampons or micro spikes. A lot of people do it in snowshoes. I'm not a big snowshoe fan unless in deep snow. Anyway, this 49-year-old man, he's about 50 meters away from the lookout when he decides to have his MI. Crushing retrosternal chest pain, and you get called, and luckily you're going in with Kayla Brawley, the emerge nurse I had mentioned before. You decide you're going to go in by helicopter. You decide to go in heavy. So you've got your full advanced medical provider kit. You've got a Zoll monitor, a defibrillator. You've got a Zoll auto pulse, and the auto pulse is the CPR machine. So you're going to go in. Unfortunately, not all the equipment fits right inside the helicopter with you. So you store some of the equipment in the side compartment of the helicopter. And Kayla helps you organize this because Kayla's been through this before and she knows what might happen. And that is, you fly in on your reconnaissance, you do a hover exit onto Dog Mountain Viewpoint, but on the hover exit, you can't reach the material that's been stored in the side of the helicopter. So basically, you've only got the equipment that you're carrying with you. But they can get you the equipment, the other equipment later when the long line comes in. On the scene with this patient is a CCU nurse, and a Mount Seymour ski patroller has gone in. Patient's complaining of 9 out of 10 chest pain. He's had this for about 40 minutes now. He's already had aspirin, astutely given by the ski patroller. but I can tell you the patient looks gray, diaphoretic, and much like crap. His vital signs are normal. He's got a good blood pressure and good pulse. Well, it's 1 in the afternoon with good weather. You've got firm snow. You're on a flat surface. But you only had part of your equipment, so you want to get the rest of that equipment to come in. You assume care from the Seymour patroller and the CCU nurse that's there. You'd like to evacuate this guy, obviously, by helicopter. You'd like to do it maybe inside the helicopter. Any sort of helicopter evacuation for this guy is going to cause a lot of stress. But you figure maybe there'll be less stress inside the machine than dangling underneath it on a rope, that is on the long line. However, command says, no, there's no good landing place around there. We haven't got a lot of people to do a long stretcher carry. Thus, it's going to be a long line rescue. Also, it'd be nice to communicate with BCEHS if this is a STEMI, because you can suggest auto launch. So getting IVs in, for me personally, I find very challenging at times. But I was heartened to know that neither Kayla nor I could get the IV on this guy, because it would have been really nice to give him some morphine. He was really uncomfortable. We gave him nitroglycerin without an IV, which I know is dodgy, but he had a really good blood pressure, and I can tell you the nitro was really effective. It really helped his pain. He still doesn't look great, but it did help his pain. He looked so bad, though, that when we packaged him, we, in addition to putting him on the monitor, of course, we put the defib pads on him, and we put the auto pulse on him because we were worried this guy could arrest at any time. We had thought ahead, can we actually shock him while in the ARP? We ran the auto pulse in the ARP, but could we actually shock him safely? We thought we could, and we were going to give it a try if we had to, but luckily we didn't have to. That was his ECG that we did on our Zola monitor, and you can see in 2, 3, and F the big tombstones and reciprocal changes laterally, and that's somebody on top of Dog Mountain took that picture as we were leaving, long lining this guy out. How often do you see the angiogram report with, in yellow on the bottom, 49-year-old man with chest pain while hiking, airlifted off Mount Seymour? This is that patient's actual angiogram report. Not surprising, the right coronary artery distally is the culprit. It had thrombus in it. He had a PCI done, and he did well. How do I know he did well? Well, like I said, isn't social media a wonderful thing? This nice reporter actually even named this man on social media, so everybody knew his name and that he was doing well, and he lived happily ever after. Case number 4, Lions Bay. A couple summers ago, you may remember there was a forest fire very close to the highway there, the Sea to Sky Highway. And a couple months after that, they went in to clear some of those standing dead trees because they were worried that they would fall. And this is only a couple hundred meters up from the highway. So it's a hot summer day, and the logging crew is cutting down some of these things. And one of the loggers, as he was cutting down a tree, the tree knocks him down, and he falls down a 40-foot embankment, and the tree rolls over him. He's complaining of really severe pelvic pain, and he can't stand and he can't walk. Like I said, hot July summer day on a south-facing slope, and it happens at 10:30 in the morning. So this is a Lions Bay SAR call, but they asked for mutual aid from North Shore Rescue for a long line. Doug Brown, as a lot of you know, is an emerge doc at Royal Columbian. He's a member of Lions Bay SAR, so he's on standby with the HEC team. Now you're going to go in just as a general member. You're not planning on going in as a doctor. You're going to go in as a general member. Lions Bay SAR is doing all the communications through their command. So you didn't know how sick this guy was necessarily. You hike in with a teammate. Teammate's name is Gordy. That's him in the light blue shirt looking at you with the sunglasses on. He's a great, highly trained first aider, does a lot of industrial medic and ski patrol. Great guy to be in the mountains with, and you hike to this guy. It's very difficult. You've got to use a hand line. You don't rappel down there, but you've got to hold on to a rope or else you fall right into the patient. It's a very steep slope. The patient's vital signs are fine. He's neurologically intact. His pelvis either was stable by the time we got there or we did it. I can't remember. His belly's benign. And basically, this is kind of boring. He's fine. He's just having a lot of pain, and we're waiting a long time. Why are we waiting a long time? Well, because they're worried about the standing trees above us, the dead standing burnt trees, and bringing a helicopter in and those things falling on us. That wouldn't be a good thing. And WorkSafe BC is also at the site. Well, we've got good weather, but it's hot and sunny and south-facing, so we actually put a tarp up at times to put some shade over the poor subject or patient. Those standing burned dead trees above you are kind of like the concept of having hang fire in avalanche parlance above you. That is, there is more stuff to come down. As for ICS, well, the loggers were there. BC Forestry representative was there. WorkSafe BC was there. This is a Lions Bay SAR call. You're a member of North Shore Rescue. It wasn't advertised as an AMP call. You didn't come with your meds, but luckily they're in the truck on the highway, but you have to hike back down to get your meds. And then the comms for the rescue are going to be by a North Shore Rescue HEC. So there's a lot of stuff going on there. And luckily this guy was stable though, but he was having a lot of pain, and this was taking a long time. So maybe giving him some analgesia would be a good idea. And again, Gravol if he's going in the long line, which he was. So they did long line him out, and Doug Brown, pictured there, did come in with North Shore Rescue and did go out with the patient, and we transferred your medical care to Doug Brown, and the guy gets brought out by long line on the ARP. And that's his bilateral sacra-ala fractures and a bit of widening of at least the left SI joint, probably both as well. But he has no neurological issues, and he does well with non-operative management. All right, the final case. 37-year-old male, skier, back of Seymour. I love this photo because of the stethoscope hanging on the ski pole right there in the center. That's awesome. It's January, it's noonish, the sky is overcast and there's poor weather, and this guy goes slack country skiing off of Seymour. And on first peak, you may have seen, there's a, skiing that pace is somewhat challenging, but it can be a good run. But he goes off the southeast side and he triggers a size 1.5 to 2 avalanche, and he gets caught in this and he's swept over that cliff to Looker's right that you see there, in your mind's eye, that is, if you know where this is, and through those large trees, and has a bit of an issue. Luckily, he's not buried, he's not unconscious, but his left thigh is severely injured, and he starts yelling, and luckily passers-by hear him. Now, you are in transit, you're driving up to Seymour because you were told the heli can't come in. Brady Warnick, who's another AMP, he's the anesthesiologist from Royal Columbian, he's going to, on route, because he's going to sort of have to drive by your search and rescue station where they keep the AMP pack, he's going to bring that to Mount Seymour and meet you up there. While Brady's at the SAR station, the helicopter magically arrives. So Brady jumps in the machine with the pack. On the radio, they say, okay, Alec, they'll pick you up at Mount Seymour parking lot. But when they got there, the cloud cover prevented this. So the helicopter decides, well, let's go take a look and see if we can get in there. They can, and they drop Brady off with the AMP pack close to the site, within about 200 meters, and Brady makes his way to the subject. But then the helicopter buggers off saying, this weather's way too bad, I'm not coming back. So Brady gets there, and he's there with the patient and bystanders, and Seymour Mountain Ski Patrol also got there. That's what the site looked like. The patroller with his back to you has nicely dug out a platform, and you can see the patients above the platform, and there's a cascade stretcher there already. There are the patient's vital signs. The patient's cool to the touch. Head, neck, back are okay. Lungs are clear. His left chest is a bit sore, but it's stable. You don't think there's anything wrong in there. His left thigh is quite swollen, quite tender at mid-thigh. You'll note mid-thighs in quotes. You'll see later. Brady's already got an IV, and I just love having an anesthesiologist on. And he's already given your patient morphine. So it's mid-afternoon. It's a steep slope that's already slid once. So the conditions are probably not all that stable, right? It's cold, there's poor visibility, the heli's left and they're not coming back. This is going to be a high angle, technical, rope rescue, and it's going to take a long time. Seymour's there. You nicely talk to them and assume care of the patient. They put an air team in, but they're already amassing a large ground team. And I can tell you, I believe there were 25 or 30 NSR members out that night. You'll see why. This guy seems to have a left femur fracture. He's got to put a traction splint on. He had a big slide. Femur fractures are, a lot of energy. Does he have other injuries? He's having a lot of pain. It's going to get cold. It's going to be a long egress. This is a big challenge. So we do a mountain PSA, procedural sedation with analgesia. So Brady gives this guy some IV ketamine while you reduce his left femur and apply a traction splint. Again, traction splints I know are controversial. You place him in the hypothermia burrito that we've talked about. Other NSR members begin to arrive, and they start to bring in all this equipment that we're going to need. Patient's placed on a vacuum mattress into that cascade stretcher, which kind of acts like a toboggan. It's a long, difficult evacuation. There's two lowering pitches that we had to do off of anchors to get the cascade stretcher and the patient down to a flat area. But then we had a long pull along this flat area and a long uphill pull back to the Mount Seymour steep area where we could put the cascade behind a snowmobile to tow him down to the parking lot when he was finally put in an ambulance. Throughout, he got a lot of stuff for pain, he got some Gravol, and we monitored his level of consciousness and monitored the traction splint continuously. It was difficult, and that's what it looked like. We were really proud of two things with this guy. After we initially got there and got our ID and started giving him meds, he did not scream again. He was screaming before we got there with his broken femur. So we're proud of the fact that he had adequate analgesia and good vital signs. Well, if you call it 88% good vital signs. We thought initially it was cold, but that probably was his oxygen saturation. But look at his temperature. He arrived normothermic. So we were pretty happy with that. And he finally got to Lionsgate Hospital 7.5 hours after his crash. There's his fractured femur. It wasn't mid-shaft, obviously. We thought it was. Questionable whether or not we should use the traction splint, but hey, we did. He had multiple left rib fractures, but no hemopneumo, and his left-sided abdominal pain was just abdominal wall muscular hematoma. There was no intra-abdominal injuries. He does well after a long recovery. So we're coming down the home stretch, gang. Stay with me now. To review, I think it's a good idea if you consider those three things for every medical call you do in the mountains. They've helped me, and my suggestion to you is that they'll help you too. So, mountain medicine, search and rescue medicine, looks pretty sexy. Hey, I want to do that. I want to join a search and rescue team. Well, I can tell you that it's not all sexy. There's a lot of hard work. I pride myself in trying to go out to all of our team's calls, not just the medical ones. And there's a lot of work behind the scenes and a lot of non-sexy, just get them back to safety calls. But I still find it quite rewarding. There is a place with in this Venn diagram that if you like outdoor adventure and you like medicine, there is a place where you can kind of do both, and that's the place from which I've tried to speak today. But you might not be able to do as much as you think you can do in the mountains. So there's limited emergency services available there. These are two really important quotes to me by people much smarter and much more experienced in the mountains and medicine than I am. Will Smith is a physician, also a paramedic and also a search and rescue member in Jackson, Wyoming, and he says, just do what matters for the patient, not what you can. And I think that's a very important concept. Another star hero of mine is Bruce Brink, and you may know Bruce from Whistler. He's a critical care paramedic and is a ski patroller. He also teaches and has his diploma in mountain medicine. And Bruce taught me that as the technical aspects of a mission increase, the medical care must decrease. And I drew that fancy little map to try to explain it to myself. This is a quote, it's a long one. It's from a paper written by a group from ICAR in their medical commission. And basically in the mountains, we have to be careful. The mountains are unforgiving and they're in charge. And both our patients and us, we face extreme temperatures, winds, wind chill factors, avalanches, falling rocks, and the persistent danger of falls. And because of this, immediate evacuation out of these austere environments is often required. Our medical tactics are dictated by those factors, and benefits and risks of medical interventions need to be carefully weighed. There's no gold standard established for austere rescue environments. Every mission is a unique combination of factors. Critical thinking on the part of the entire team is paramount, and it's that critical thinking I tried to speak to today. That's Crown Mountain. That's Crown Mountain from the north. Many of you know Crown Mountain. It's sort of behind Grouse. If you look at the Grouse Mountain, sort of massive, it's sort of the peaky top. And for those of you with good eyes, you'll see something sort of orange colored in the center of this photo. That's you. That's you doing search and rescue medicine. Trying to help people, trying to have fun, but always keeping yourself and your patients, your subjects safe. That's the end of my talk, and I'm happy to take questions.
Dr. Ritchie, thank you very much. Alec, there's actually no questions so far, so I'll ask one as well. But before I do,
is there anybody watching? I wonder, maybe.
No, you've got 120 people watching here, and they're all spellbound, and most of them seem to be taking notes as well. So thank you very, very much for the presentation, and also thanks to Janet Chung in the background for putting this on for us as well. Just a quick question from me, because we're going to segue into the next rounds in 3 minutes, is you mentioned a research paper in progress, and what you have here is a fascinating mixture of patient pathology and geomatics. Can you tell us a little bit more about that research paper?
Sure. Well, North Shore Rescue is actually over 50 years old, and we wanted to look at everything right back to inception. But the early stuff was written on the back of a Kleenex and is now gone. Even going back 20 years was difficult because a lot of the note-taking wasn't great. Part of our research will actually help inform note-taking in the future for how we want to record what happens in these calls and what happens with patient injuries and that sort of thing. So basically, it's retrospective. It's just looking at every single call for 25 years, teasing out the medical ones, and of those medical ones to get as much information about what the medical problem was, documenting that, and then publishing it.
All right. On that note, there's a lot of positive comments in the chat, and we will call it a morning. And thank you again very much, and we'll move to the next rounds. Thank you, everybody.